Kendrick, you can start.
Yep. Thank you, Professor Natarajan. So next, I'd like to introduce Dr. Talma. Dr. Talma is from South Africa, and you might remember him from the recent WOC 2020, where Dr. Talma was one of the specialty coordinators, particularly for ophthalmic trauma. Just to introduce Dr. Talma, so he's currently a consultant at the Pretoria Medical School, also chief consultant at the First Military Hospital. He's the president of the Ophthalmic Society in South Africa, and also the president of the Cataract and Refractive Surgery Society. He also was involved in a lot of charity. So he was a founder and trustee of the Right to Sight Charity Trust. And he is also founder of a number of businesses, including the Pretoria Eye Institute. He's also a director for the National Hospital Network. So today, Dr. Talma's talk will be on ophthalmic trauma and African perspective in terms of the challenges and opportunities. So thank you, Dr. Talma.
Thank you very much. If I may, I think, thank you for the opportunity. I think I'm delighted to be here, and thank you for this brilliant webinar. I think it's fantastic. My aim is a bit different than the COVID. In South Africa and Africa, we do more or less the same as all over the world. I think our trauma profile is slightly different. And maybe we can later discuss that. But our aim is just to explain a bit on a way if we want to create a trauma society for Africa. We have trauma is very common, but we do not have a society in Africa at all, as far as I know. And I think it will be a good idea how we can overcome the challenges. But before we do that, I think it's important to understand the dynamics of Africa and the challenges we all have in Africa. And if one understands that, it's easier to understand where we're going to. Financial disclosures, I've got none to declare. I think as background to ophthalmology service delivery, the realities of the African continent are very important. The current situation and future opportunities in terms of healthcare and trauma care. There are many factors, like in any country. In Africa, I think economical and social situation is a major factor. Disease burden, the management of healthcare systems, mostly by states. Human resources is a big factor. Logistics, and in the areas where there's private sector, we have corporatization and business ethics. Managed care like in the US, but a bit more to the extreme. And COVID is more on the economic effect than anything else. So I like just to repeat, I think some of you might have seen these slides, and this is the realities of the world we live in. And within these constraints, we as doctors have to function for good or for bad. It gives us hurdles, but it's also opportunities. If we look at national income, it's an important factor in healthcare, and eventually our ability to deliver comprehensive care, also trauma care. If we look at violent deaths, and this is a bit different than the rest of the world, you see in Africa it's pretty high, and it's also related to dominant factors include efficiency of governments, management ability, corruption levels, and all other factors. Accidental deaths are slightly less, and they're a bit more in the area of India and China, according to the World Mapper. And if we look at all injury-related deaths, we see the indications are also more to Asia than in Africa as such. But let's look at incidence of trauma cases. We have two structures in Africa. Most countries, you have the state sector, the public sector with a mass of people, and a selective smaller private sector. In the state sector, 2.2% of new cases, 6% of outpatient clinics is trauma. So it's part of daily life. In the private sector, more like Europe, 0.14%, 0.7% in the private sector, which is probably what you experience. Major injuries are very common, and this is managed from a registrar level later on. But why do we need to look differently at trauma? Personally, I see this a patient I saw waiting time before surgery 2 weeks. And this is not because of COVID, this was just before COVID. And this is the type of dilemmas we have in our world where we're coming from. blinding disease. This is more to glaucoma, cataract, and diabetes. But big part of the dilemma is physicians working, and that's in general physicians working. And this from the British Journal of Ophthalmology, ophthalmologists in the world. And you see in Africa, we have at the lower end a very low number of ophthalmologists per million of the population. In the upper part, northern side of Africa, the stats and Asia, it looks much better. So that is the realities within which we work. Average worldwide, 31 ophthalmologists per million. Sub-Saharan Africa, we work on 2.8 million in English-speaking countries. French countries, 2.2 per million. Portuguese, 1.2 ophthalmologists per million. Worldwide, we know there are 14 countries with less than 1 ophthalmologist per million, 31 countries 1 and 3, and only 13 countries more than 100 per million. So 100-fold difference. And I think that's a challenge we have to live with. Population of Africa is 1.3 billion. There's guesstimates it might double in 30 years' time. And once again, we see the populations in some countries where we have pretty low number of ophthalmologists per million of the population. In our country, we have 6.3, Botswana 5.4, but the larger numbers are in private sector and less working in the state. But this sounds all doom and gloom, but in exchange, we have excellent surgical skills. If we see someone to start his residence and he hasn't done 100 or 200 cataract operations before he starts even his training, he won't be taken very serious. And during the training, practical surgery is done on a daily basis. So the scope is that anterior posterior segment surgical skills are trained to registrar. And when they complete their residency, they're pretty competent in it. And so trauma is managed usually by people who do the whole full spectrum of trauma. Anterior, posterior, even orbital trauma can be done often in one sitting. And this is the advantage and the luck we have on our side. For APOTS and other societies to talk to Africa is often difficult. There are societies in each country, which wasn't the case long ago. Under the ICO leadership, there's been 2 big groupings, the African Ophthalmology Council, which represents Sub-Saharan Africa, East, West, Central, Southern Africa. And then there's MIACO, North Africa, Middle East, Turkey, and even Iran. And these are 2 very well organized organizations, and that can be used as a vehicle to implement, as our chairman has said, what they want to do in future. But quickly, let's get back to basics again. In Africa, we must realize there are a lot of various healthcare models, but in essence, it's all the same. We have a state system and often a partly private sector. If we look in South Africa, we see 45 million government sector, 10 million private sector, 5 million both. The state sector is a combination of first, second, and third world level, private, first world sectors. And in general, we see the facilities, not necessarily the staffing, but the facilities are excellent in both sectors all over. And infrastructure and equipment is surprisingly good, even in remotest parts of Africa. And that's always a surprise when one visits these areas. In the private sector, doctors are available 24/7, surgical skills are excellent. State sector, pretty good, but the burden is massive. Cataract backlog, there's arguments on the level, but maybe 160,000 just in our country. Private sector, all the bells and whistles you can dream of, you can do what you like, and there is massive infrastructure and skills available. And neighboring Lesotho, even 3 operating beds in one theater works well, excellent work done by highly skilled surgeons in those areas. Anesthetics, usually not a problem. Anesthetic nurses are not common, and ophthalmologists often do local anesthetics. And then if we look just to highlight the contrast in our continent, and that's where we must think about. If we see the blue line, it's a bit confusing slide, but we see our private sector being rated by Monitor Studies as number 4 or 5 in the world in terms of access, cost, and quality. But the total of our country is pretty low because of the public sector where there's major problems. So if we look, that's why it's not surprising to see that the first lens was implanted, LASIK research done, first heart transplant in South Africa. But the moral of the story is, what do we do? What do we as professionals do for Africa? And that's my plea. Are we hanging around and see and wait? No. I think we must challenge the challenges and tackle the elephants in the room, which often is linked to politicians, governments, insurers, big business. And I think we as doctors must try and challenge those. If we do that with your help from the outside international community, we can do a lot, not only for trauma, but for all our patients. And in summary, for the whole of Africa, we have dual systems all over the place, mostly. The rich, small percentages, the poor, second, third world, and often driven by economic performance. The positive side, their skills are excellent, and the professionals are very skilled and very easy to handle complex cases. And the facilities are in general not bad. But on the negative side is that ophthalmologists, the numbers are very limited for patients. Trauma is delivered often by residents and junior staff with limited direct supervision. It's often delivered after hours and with the next day surgery in the private sector sometimes, and in public sector with long waiting times and logistics. If we look at if you see in a country like Botswana, there are sometimes patients who have to travel 500 kilometers to get to a reasonable facility. Now, this is for poor people, obviously, sentence on their vision in the long term. So what can we do? There are two segments, macro-environment and micro-environment. The macro-environment probably lies with governments, dual systems, overwhelming workload, logistical problems. The micro-environment, we can do something about. And that's to create, in our instance, awareness of the complexity of trauma cases. And this should be managed by the higher skills professionals, also over weekends and public holidays and Christmas. So obstructions in the referral systems. And these are the things that we must look at, I think, as ophthalmologists. What can APOTS and ISOT maybe do in Africa? Once again, macro environment, communicate with macro organizations like the African Ophthalmology Council, the Middle East African Council, and others. On the micro environment, awareness of the complexity. Interact with the societies. They're so keen. They all have congresses and maybe offer to international speakers. And Ferenc Keen has been fantastic. He's nearly an honorary citizen of our country with all these visits. And he's done so much. Ferenc, thank you so much. And I think being involved in training at universities, and then let's start and create special interest societies, special interest groups. And I think that is maybe a way forward for the international community to help trauma in Africa, which is a major factor. And once again, these two organizations. So, Chair, I hope this gives you a very quick overview of what happens in Africa. There are societies in each country, and doctors are very keen, but maybe need some help and advice that you can offer us. Thank you very much.
Thank you very much, Dr. Talma. I'm always enlightened when I listen to you and really sharing the challenges, the successes that you faced. And I now know that South Africa is going through its own challenge now with the same COVID virus. And you were relating earlier on to alcohol playing a role, men playing a role, which is a common risk factor for trauma all around the world. And it'll be good to hear in the panel discussion, what are the things you've done to overcome some of these challenges. Thank you very much, Dr. Talma.
Pleasure. Thank you very much.
Can I make
Thank you, Dr. Talma.
Yes.
No, yesterday I saw a patient from Botswana in my clinic, and I told him, why not we start a tele-ophthalmology, where I think there are optometrists more than the very few ophthalmologists in Botswana. So something like that, I think we can think. Maybe we'll discuss that in the panel.
Yes.
Right.
Pleasure.